So I'm going to introduce our next speaker, which is Professor Adam Frampton from the Royal Surrey Hospital, Guildford, which is one of the pioneers of robotic surgery, certainly helped by their prolific access to robots, which was coordinated by their clinical lead, who happened to be HPB. So Adam trained in and around London and is also a surgeon scientist, and he runs a lab within the University of Surrey and is also head of oncology there. Now, he's actually going to tell us whether the UK has actually caught up with the rest of the world. So he'll fill in that gap, which, you know, Joe's very complimentary about UK, but let's hear the grim truth.
Thanks to Jared and the organising committee for inviting me to speak. Morning, everyone. This is the title of my talk. This is an outline. Thanks to Intuitive, I don't know if they're in the room, for providing some of the data and slides that I'll show you. So minimally invasive HPB surgery has expanded over the last few decades to help us deal with the complexities and challenges that we have to deal with in our specialty, and it's now a routine practice for the majority of us in the room. The pioneers of minimally invasive HPB surgery performed the first laparoscopic cholecystectomy in 1985, and then just 9 years later, the first laparoscopic Whipple. 4 years after that, or 3 years after that, the first robotic cholecystectomy was performed, and that was the first human use of the Da Vinci system. And then a few years later, the first robotic Whipple. So there's been a rapid expansion of laparoscopic surgery in HPB, but why is a robot needed? Why aren't we all doing laparoscopic Whipples? Why aren't we all doing laparoscopic major hepatectomy? I put it to you that laparoscopic HPB surgery has been poorly adopted in the UK and worldwide for these reasons. It's technically difficult. There was no real standardized training, difficult to learn, and perhaps also cultural resistance, with a few surgeons perfecting it and working in silo. So I'm sure you'll agree there are considerable advantages to using the robot in HPB surgery, and definite benefits over open and laparoscopic approach if surgeons are trained properly and work in high volume units. This, of course, has been driven mainly by Intuitive and the Da Vinci monopoly, with, I'm sure, majority of you training and using the Da Vinci Xi and some of the newer systems. But of course, now there are many newer robots on the market, all with specific surgical, endoscopic and endovascular applications, allowing more surgeons to adopt the robot into their practice. So as HPB surgeons, I think that we are aroused by the robot. It allows us to do challenging operations whilst developing new skills, and it is easier, in my opinion, to achieve a flow state with the robot. Of course, that is the mental state of complete absorption and optimal performance, or what's also known as being in the zone, which does lead to improved patient outcomes. And so I think that it's easier to achieve the flow or the flow state with robotic surgery for these reasons: that you're fully immersed in the task, immune to distractions. There's an ability to do preoperative rehearsal, post-operative reflection with videos, optimize your team, for example, dual console, 2-consultant operating, and you know, teaching your robotic HPB staff in your operating rooms, and then, of course, integrating technology into your procedures. And with that, easier to achieve flow state, of course, comes a faster learning curve. So this is a standard or classic learning curve for a surgeon, with slow progress in phase 1, followed by gaining competencies and accelerated performance in phase 2, and then mastery, and then perhaps descent to the golf course. But for the robot, there is an alternative learning curve, with a rapid ascent in phase 1, where the robot surgeon is able to grasp complex procedure before competency is actually achieved, due to early acquisition of skills from formal training programs, followed by a slower ascent, and then, unfortunately, for some robot surgeons, a temporary deterioration where he or she takes on more difficult cases, for example, morbidly obese patients post-neoadjuvant chemotherapy, post-pancreatitis, aberrant anatomy, and then a final plateau in mastery before descent. And what many studies have shown is that novice surgeons are able to climb the learning curve much faster for the robotic approach compared to laparoscopy, and that advanced laparoscopic surgeons can climb their robotic learning curve even faster. So many studies have shown that junior and senior surgical trainees can learn on the robot much faster than laparoscopically. When you compare open to laparoscopic to robot-assisted surgery, I think now that many of the disadvantages of the robot are disappearing. Of course, there's always going to be an expense with an initial investment required, but hopefully costs should come down as we start to realize the reduced length of stay and reduced complications, and perhaps use contracts such as pay-per-use. Of course, new robots should hopefully create competition in the marketplace and reduce costs. No haptic feedback is no longer a thing with the Da Vinci 5, and of course, the Da Vinci systems and other robotic platforms have artificial intelligence and other enhancements that can help our surgical performance. High training costs and training not being readily available is just not true. As Jared mentioned, we have 2 UK robot proctors now, as well as seminars, webinars, courses, tons of online videos from some of the international faculty in the room, biotissue models, frameworks, consensus guidelines, and then the liver and pancreas training programs in Europe. With regards to oncological outcomes, again, several studies have shown that outcomes are probably equivalent or even better on the robot. Just talking about costs should hopefully come down for these reasons, allowing more surgeons around the world to adopt the robot. So going on to some data from Intuitive, now there are approximately 17 million procedures performed to date, with about 11,000 robots installed globally and 43,000 peer-reviewed publications. I did a PubMed search. Oh, sorry. This is just to show the growth year on year, 17% last year, and predicted growth is 13 to 16% this year. I did a PubMed search, and actually, if you look at robotic HPB surgical original articles, you can see the exponential rise from 2010 and almost 250 articles published last year. Looking at the current landscape of the UK, Jared already mentioned this. There are 9 centres out of 29 in the UK that are level 3 in pancreas and liver, and only a few that are left to start. The Da Vinci data again indicated for HPB robotic use in the UK, exponential rise since 2014 when the Da Vinci Xi came out. And if we look at the HES data for HPB cancer in the UK, you can see a rise in the dark blue line at the bottom in robotic use with a tail off of open approach. For liver resections for cancer in the UK, this is HES data again. Again, a steady increase in robotic liver resections, but many surgeons are still doing laparoscopic liver resections. When we focus down on this data, this first time period comparing the UK to Guildford, 2017 to 2020, the majority of liver resections being done by the open approach, 1.34% being done by the robotic approach nationally, and in the second time period, 2021 to 2024, nationally this increased to 6%. At Guildford, we managed to get it up to 23%. Then looking at worldwide pancreatic resections, this is again on the Da Vinci system, exponential growth since 2012. And of course, this scale is different, but growth year on year is actually much steeper for the UK for pancreatic resection. Looking at the HES data for pancreatic resection for all cancers in the UK, obviously a rapid adoption for pancreatic resections by the robot with tailing off of the open and laparoscopic approaches. And then looking at the Whipples, well, again, a rise in robotic Whipple numbers, but laparoscopic Whipple is now no longer being performed in the UK. Looking at the data in more detail again, the first time period for all pancreatic resections, majority being done by the open approach with only 1.34% being done robotically. And in the second time period, nationally, this rose to 7%. And at Guildford, we managed to get it up to 28.7%. Same looking at the data for the distal pancreatectomies, 2/3 being done open in the first time period, 1/3 laparoscopically, and 4% robotically, which increased to 15 or 16% in the second time period, and 43% at Guildford. And then finally, for the Whipples, in the first time period, majority of cases being done open, 1.23% being done robotically, which rose to 4% in the second period for nationally, and 6% at Guildford. So in conclusion, worldwide adoption of robotic HPB surgery has been exponential, and as Jared mentioned, we're finally catching up in the UK. The robotic surgical field is expected to advance by leaps and bounds with new software, technology, and robotic systems. Of course, these will have to be compared or benchmarked to the gold standard Da Vinci systems. And further worldwide adoption will depend actually on the applicability to our patients, whether these technological developments will translate into patient benefit. Thank you very much.
Thank you very much for keeping bang on to time. It's almost like you practiced. Has anybody got any questions for Adam? So I've got a question. So the American data would suggest about 25% of Whipples were being done robotically in 2015. So I know Jared suggested we've caught up. How long do you think it'll be before we're hitting those sort of numbers here in the UK? And I'm still talking about that's 10 years ago in America.
If you look at the curves, actually we've only, I showed you that steep curve, but actually when you look at the scale, it's only 10% in that time period. So, I don't know, another decade perhaps.
Thank you very much. I find that quite depressing.